Hi, I'm Bob Eckel. I'm one of the co-chairs of the Cardiometabolic Health Congress, currently in its 17th annual presentation of updates in cardiometabolic disease. Today's been a pre-conference topic on cardiometabolic health and related disorders in older patients. And I have some of the people presenting at that conference today with me right now. I'm going to ask each one of them to introduce themselves. We'll start with you, Joe.
Hello, my name is Joseph Saseen. I'm a professor and associate dean for clinical affairs at the University of Colorado Anschutz Medical Campus. I'm a clinical pharmacist and happy to be here.
Marie?
Hi, I'm Marie McDonnell, and I am the director of the clinical diabetes program at Brigham and Women's Hospital and chief of the diabetes section in the Division of Endocrinology. I'm an endocrinologist and also very happy to be with everybody here.
Hello, I'm Ken Feingold, and I'm also an endocrinologist, and I worked at the University of California, San Francisco Medical School, and I'm now retired and the editor-in-chief of Endotext.
Well, Ken said retired, but I think he's kind of like me, rewired. But
More or
anyway,
less.
all that aside. Well, we had a series of presentations. This is the second half of the program here this afternoon. And Ken, you led off with discussion of lipid management in our older patients. Can you kind of summarize kind of the take-home message that you brought to the audience here this afternoon?
Yes, I think it can do that really simply. I think in elderly patients with atherosclerotic cardiovascular disease, we should treat them very similar to the way we treat younger patients with atherosclerotic cardiovascular disease. Basically, they should be on statin therapy and, if needed, additional medications to get their LDLs down to goal. In elderly patients without ASCVD, I think we need to use some clinical judgment, because if you use the usual calculators, you will find all of those patients being at moderate to high risk. You therefore have to use other factors to help you decide whether you should treat those individuals or just observe those individuals. Some of the other factors are the other risk factors for cardiovascular disease, particularly Lp(a). One can also obtain coronary artery calcium scores to help you make these decisions in these difficult patients.
So Ken, one thing that didn't come up today, either in the questions to follow or during your presentation, is the whole issue of EPA in terms of implementing EPA therapy in people at higher risk, perhaps based on the REDUCE-IT trial, people who are hypertriglyceridemic. Do we have any data at all, even retrospectively, about triglycerides and cardiovascular disease in our older adults and or the value of EPA in that particular setting?
Well, the VASEPA study, the REDUCE-IT trial that you talked about, actually did provide data on patients older than 65. And I know for some of us we don't consider that elderly, but nevertheless they provided data, and it looked pretty much the same as it did for the younger individuals. Unfortunately, I haven't seen data for the over 75 age group from that study.
The whole definition of older comes up to question, doesn't it?
Yes, it becomes very difficult as one gets older.
And I think, Marie, you made a great point with some of the pictures you were showing. We saw a series of individuals who all could have been above the age of 65, maybe some were, some weren't, and I don't know that I could distinguish it. So do you want to comment on that in relationship to treatment of type 2 diabetes, which is so common in our older folks?
Yes, I think we know that there's a spectrum of people who are older in terms of overall health. So, and there's data to support the concept that if we think about our patient in terms of their overall health, which includes functional status, probably should include frailty, as we learned about a little today too, then we would actually make different choices about their medical care. So we know that cognitive impairment, for example, predicts mortality. In the next 10 years, there's a higher mortality rate if you have cognitive impairment versus if you don't. So clinicians know these things about their patients and can help them make choices about treatment strategies that may or may not benefit them in the short term. So a good example is glycemic control. So if we have a patient who, what I said in my talk, is the one that's most likely to be entered into a clinical trial. These are folks who have really good overall health in general, even though they could be 75. That individual might actually benefit from 10 more years of really good glycemic control to control their microvascular complications. In the meantime, you're going to think about their heart, treat them, make sure they're on a statin and their blood pressure is controlled. In an older adult who's more complex, there's dementia, you're thinking a little bit more about avoiding hypoglycemia, which may accelerate cognitive decline and accelerate their risk of death. So then we're thinking more about quality of life, potentially protecting them from macrovascular events. So you might choose one of the novel agents, well, not so novel anymore, but you might actually be more likely to choose a GLP-1 receptor agonist or even an SGLT2 inhibitor in a patient you're trying to modify their event rate, their risk of a macrovascular event, versus choosing glucose control as your primary goal, if that makes sense.
It reflects on some of the early trials with SGLT2 inhibitors and GLP-1 receptor agonists where the outcome wasn't related to glycemic control, but other benefits that relate to these two classes of drugs.
Right. Yep.
So Joe, you talked a lot about polypharmacy here in the older adult, much more common in that population. How can the clinician in the clinic with a fairly short visit assess for the presence of polypharmacy? And moreover, what's the role of the PharmD in the clinic in terms of enhancing the definition and also the implementation of changes in pharmacotherapy that relate to less drug interaction?
Sure, those are great questions. And I think overall healthcare, especially with cardiometabolic risk, ideally is a team-based approach to providing the best care possible. Because we do have patients that have long medication lists, and the definition of polypharmacy really is the inappropriate use of medications together. With our population with cardiometabolic disorders, we have diseases that have evidence-based therapy, so it's hard to get away from using a few number of medicines in your patients with multiple comorbidities. But it really is trying to tease out those combinations and those medications that do no longer have an indication or are dosed inappropriately because of age-based needs or organ-based changes that would require a lower dose perhaps, or switching from a safe or a less safe drug to a more safe drug in the context of some of these diseases. Using a clinical pharmacist that's embedded as part of your team, I think can be a useful tool to help go through those medication regimens to really tease out when you have inappropriate combinations or less effective ones.
One thing that didn't come across in your talk, this is not a criticism, but just an observation, is most of the drug interactions occur with drugs that are generic and cheaper. We know that cost is a major issue. So can you at least superficially address this issue of cost and drug interaction?
Yeah, that's a great observation because older drugs are more affordable because they're generic. And as drug development evolves, drug companies have learned how to, learn from previous mistakes. So a statin that comes out, such as lovastatin, as the first statin out there, has the most drug interactions in comparison. And as you further develop and refine the pharmacologic options, you have fewer and fewer drug-drug interactions. You may not have fewer side effects unless they're subsequent or explained by a drug interaction. So when we look at multiple medications and affordability concerns amongst all of our patients, especially as they age, that opportunity to have a drug-drug interaction with medications that are affordable and generic is going to have a higher risk than some of our newer agents, sort of a truthful reality.
Ken, you mentioned something that's quite important, I think, in our older subjects who are not on statins or ultimately on a low dose of statins, the importance of titration of dose upwards to avoid adverse effects. In general, for a younger patient who ultimately has an event, we treat with high-intensity statins immediately unless there's some contraindication. Your thought about titration in our older adults?
I think you have to base it on the patient. Obviously, the older, the sicker, the other more metabolic problems that the patient has, things like liver disease, renal disease, I will tend to go slower in that kind of patient than an 80-year-old who's just finished his third marathon this year, who I may use a full dose.
We see some of those patients.
You do see some of those. The other thing is I think that you can always use the concept of combinations, and using a low dose of a statin with a drug like ezetimibe, using two relatively cheap generic drugs, and therefore avoiding the high doses that are more likely to get you into trouble. And with using statin plus ezetimibe, you can get the same LDL reductions as you would with a high dose of a statin, so that you actually get the same benefits without the increased risk.
Well, the guidelines suggest that maybe 55 is our target, but we know that lower is better in general, although I don't think the clinical trials clearly show yet that 35 is better than 50. But all that aside, are you going to have the same goal for LDL cholesterol lowering in an older patient who is not frail and not disabled in terms of the amount of LDL lowering you want to achieve?
Yes, I think all things being equal, I'm going to be going for the same endpoints with LDL because I think that will have the same beneficial effects on cardiovascular outcomes as it would in a young person. I think you'll get the same benefits in an old person. I mean, the only exceptions I would make for this, and this has to do with whether you even use statin therapy, is if you have someone who's in a nursing home with dementia or bad frailty, where you're really looking at a very short life expectancy and you don't think that you're going to get any benefits by reducing cardiovascular disease in that particular patient. But other than that group of patients, I think you're going to treat them pretty much like you do younger individuals.
Okay, Marie, the issue of glucose control, I mean, the cardiologists in general, I'm generalizing now, think it's totally unimportant, but some still think it has some relevance. But based on ACCORD and ADVANCE and VADT, to dismiss it entirely, I think is inappropriate. Do you agree with that, and what's your thought about that?
Yeah, I do. I think, first of all, we do know that glucose control does appear to be related to cardiovascular health, because we know that in the long study, randomized trials that were long duration, so the DCCT and the UKPDS, so type 1 and type 2, when patients were followed over a longer period of time, UKPDS, it was 30 years, we saw that those who achieved and maintained over time better control had fewer cardiovascular events. It's hard to look at that data and treat it the same way as the primary study, because those events were not as detailed as far as adjudicated in a detailed way, but it was well done, and I think that was helpful for those of us trying to figure out how tight we should be with glucose control. And so what I would say is, the ACCORD study was really the big study that turned people off to glycemic control. And what that study showed is that in the arm where the A1C target was less than 6.5 versus those who are treated more closer to 7.5, there were more cardiovascular deaths. When we look at the people who died, they were those who actually didn't achieve the target.
That's right.
Do you remember that?
That's an important.
It's so important. It's those who actually, in my view, those who couldn't do it. Some people say they were more insulin. Some people say, meaning we don't know, maybe they were more insulin resistant. They needed more therapy than others, and that therapy could have been the problem. We don't know. As insulin therapy, for example, or maybe they had more hypoglycemic events, which wasn't totally clear.
Or more variability, and perhaps that put them at greater risk
exactly.
for outcomes.
Yep. I will say one more thing here, which is we didn't use GLP-1 receptor agonists in that study, and I think that if we did, we would probably have a different outcome, right?
Right.
What did you think of the grade results with liraglutide?
Yeah, I mean, what we saw with the initial report, we know that there'll be subsequent, that it's a good drug, and we probably should be using it sooner, but insulin's also very effective for glucose lowering, but we already knew that.
How new?
I know, who knew?
But what did you think of the cardiovascular outcomes in the GRADE study?
One thing that comes up, Joe, I think in clinicians' minds who are not PharmDs in the clinic is the distinction between pharmacodynamics and pharmacokinetics. And you went over that a little bit, but for our audience here, listening audience, could you help us along that line a little bit?
Sure. I think that's pretty easy and straightforward for me to explain. There's two types of drug interactions. You can have pharmacokinetic or pharmacodynamic. Pharmacokinetic really means that it's a drug interaction, combination of two drugs where the object drug has a change in the drug concentration, goes up or goes down. That's a kinetic change because of a change in elimination or absorption or distribution of the drug. The pharmacodynamic combinations or interactions are when you use two drugs together that share the same side effect profile, so that when you use them together, that's accentuated. Right. For example, an ARB with spironolactone or mineralocorticoid receptor antagonist, both can cause hyperkalemia dyslipidemia or colchicine with a statin. Both can cause myalgia. So you use them together and it goes up.
So would you say by far the most common interaction that people face in the clinic is pharmacokinetic and not pharmacodynamic?
I think for the most part, yes, because at least the ones that are easy to measure because of what we know about the metabolism of the drugs. And most of those common ones would be drug interactions that are decrease in metabolism, drug metabolism in the liver.
Competition for substrate with inhibitors or...
Yeah, or the ones that are real inhibitors or inducers.
Right, okay. Well, I'm going to thank Dr. Saseen, McDonnell, and Feingold for joining us here. I hope this dialogue after the event today is helpful for you in terms of implementing changes in your practice that are evidence-based and relate to better care of patients with cardiometabolic disease in your older subjects. Thank you.